Thank you very much. I really appreciate the invitation to come and speak with you. Now, I do want to just get a sense of my audience, if that's okay, because some of the stuff I talked about is can get a little technical, and so I just want to know who I'm speaking to. So first, if there are any patients here, would you mind putting your hands up? Cancer patients? Yes. Any caregivers of cancer patients? Yes. Any healthcare providers? Okay, very good. So let me just tell you that, genetics gets a little complicated. So if I do start to go off on a tangent and I've lost you, please stop me and ask me to clarify, because it's likely, in all likelihood, there's someone else who I've also lost, okay? And we'll have plenty of time for that to be built in. So yes, I'm asking this question of whether all cancer is genetic in origin, and I hope by the end of this you'll understand some of the differences between what we talk about in terms of the most common cancers, which are spontaneous cancers, but also hereditary cancers. So we'll get into that in a bit, but also what I want to emphasize during this talk is the role that geneticists and genetic counselors in particular play in the evaluation of cancer patients. And then we'll talk a little bit about some common genetic testing that we utilize to help differentiate different groups and different populations who may be at greater or lower risk of cancer. And if we have time, I have a little bit of some relatively new things that are coming out that may make our future very exciting for cancer, particularly from the genetic standpoint. So we all know cancer is a very, very common disorder. In fact, 1 out of every 2 men and 1 out of every 3 women will develop cancer over the course of their lifetime. The types of cancer that we see, at least the primary ones, are different because of biology. So for men, the most common is prostate cancer, whereas for women it's breast cancer. But the second and third most common cancers, lung and colorectal cancer, are common across the board. And the 2 biggest risk factors for cancer are your age, and we'll explain the biology of that in a minute, but also environmental exposures that you have. Genetics does come in and plays a role, and partially it's because of both age and environment, and I'll touch on that momentarily. So when we think about cancer, what is cancer fundamentally? Fundamentally, it is a problem in growth, cell growth. So all cells are supposed to grow and multiply and divide at a very, very well-regulated rate. Okay? And there's a whole series of systems that make sure that that growth doesn't go too fast or too slow. Particularly with cancer, the 2 categories of genes that contribute to how your growth is regulated are what we call the oncogenes and the tumor suppressor genes. The oncogenes are genes that encourage growth, so you can see it trying to pull the car through the stoplight, and the tumor suppressor genes serve as the brakes to kind of slow things down. And it's that balance between the 2 that ensures we're growing at a normal rate, not too fast and not too slow. Oncogenes, as I mentioned, they are genes that stimulate growth, but they are well-regulated genes, meaning they have a series of switches that tell them when to turn on and when to turn off. These are genes that are involved, very important, in cell signaling, meaning how one cell communicates to another cell, how DNA is repaired, because we know that DNA accumulates damage over time, and so we have a system to repair that. And then things that regulate the cell cycle. And we're talking about the cell cycle. We're talking about how the cell decides at which point in time it needs to divide, and then sort of hold off on division. When oncogenes become a problem is when they get a change or a mutation that gives them a new function or increases their expression. And so that regulatory mechanism that I was mentioning, that switch that controls it, is suddenly broken, and then the gene is just on all the time, so there's no regulation anymore. Usually, when we see these kinds of mutations, they're not present in every cell of the person's body, but usually in a particular tissue that then is becoming more predisposed to cancer. And we call those somatic level changes, as opposed to germline. Germline refers to the sperm and the egg that gave rise to you, and so anything that happened in the germline should be present in every cell of your body, because that's where it all originated. Somatic changes happen after you've already developed, and therefore are going to be isolated to the tissue where the mutation arose. Okay? And one of the more common, at least hereditary cancer syndromes that we think about that are due to oncogenes is a gene called RET. And RET seems to be a very important gene in the regulation of growth, particularly in endocrine tissues, so all your glands. And if you have a mutation in RET that takes away the regulation of it, then we start to see tumors appearing in multiple hormonal systems. And this condition is called multiple endocrine neoplasia. Okay, just as an example. The way we think about the oncogenes is that these are the genes that want to press on the gas, right, to accelerate the car. And so even though we have 2 copies of the oncogenes, because you get one from your mom and one from your dad, if you get a mutation in just one copy, even though this other copy is well regulated, it doesn't matter, because that mutated copy is already accelerating growth. And off you go, and cancer can develop. And so oncogenes, one mutation in an oncogene is sufficient to have a role in cancer development. And you'll see how this is slightly different than the tumor suppressor genes. So opposing the oncogene are the tumor suppressor genes. And these are the genes that are constantly trying to slow cell growth down. They are also important in cell signaling, but they have a much more important role in how cells differentiate, meaning when a cell is trying to decide, am I going to be a blood cell or a bone cell or a heart cell, this is where the tumor suppressor genes play a role. And then also, you have to have a controlled way for a cell to die. There are points in time when cells are no longer needed, and it's the tumor suppressor genes that said, you know what, your time is done, we don't need you anymore, and send you on your way. The types of changes in tumor suppressor genes that lead to cancer, different from oncogenes, are what we call loss of function mutations. So these are mutations that basically disrupt the ability of the tumor suppressor gene to do its job. And so once you lose that ability, you no longer have a good control over cell growth. In tumor suppressor genes, at least from our genetics perspective, it's the germline mutations that are responsible for hereditary cancer syndromes. So the most common one I think that most people are aware of are the BRCA1 and 2, the hereditary breast cancer. And that's due to mutations that arise early or are already present in the sperm or the egg cell that gives rise to the individual, and therefore the mutation is present in every cell of the body. And then if we go back to our car model that's sort of driving towards this wall, again, we have 2 copies of every tumor suppressor gene, because you get one from mom and one from dad, and they both work to regulate cell growth. And if you get a mutation in one, you still have this other functioning copy. So even though the tumor suppressor gene here has been taken out, you're at 50% level of your tumor suppression. So you are susceptible now to developing cancer, but you're not automatically going to get cancer because that second gene is still working. It takes a second hit or a second loss of that other gene before you will then you'll actually develop cancer. Because in this case, we've sort of completely removed the braking system, and now we're gone. So whereas before we had brakes only on the front wheel, not on the back wheel, now it's all out. So there are slightly different mechanisms when you look at oncogenes versus tumor suppressor genes and how you can develop cancer. Everyone with me so far? Okay, good. Now, I've been talking about it like it's just one mutation that leads to cancer, and that's not entirely accurate. It's actually a series of mutations that result in cancer. So here we have a diagram that starts us with this, it doesn't show up so well. Oh, on the screen. Okay, well, I'm just going to have to point that. We're starting off with a normal somatic cell. So, say this is a cell in breast tissue. And because of environmental exposures, UV radiation, when you walk out today, there's actually sun, and so, you can accumulate changes in your DNA because of that. Cosmic radiation, X-rays, all sorts of things. You will accumulate a first mutation. And that first mutation may involve a gene that's important in cell cycle control. Now, by itself, it's not going to cause cancer, but the cell that inherited this mutation now has a slight advantage in terms of growth rate compared to all the other cells in that tissue. Okay? So now this cell is growing at a slightly faster rate, and when cells start to grow at a faster rate, the ability of the cell to correct any additional DNA mutations that are rising is slightly diminished. Because think about this. It's like you're given a paper, to edit, and you're just checking it for grammar and spelling. And you're given an hour to do it, and you can do your job pretty well. Now you're given the same paper, but you only have 30 minutes to do the same job. You may start to miss some errors in that case because you just didn't have enough time to do that. It's the same thing here. When the cell is starting to grow at a faster rate, there's less time for those repair mechanisms to correct any errors that are accumulating, and therefore that cell is now predisposed to developing a second mutation. And so it's almost like a snowball effect. So now you get a second mutation, the cell starts to grow even faster, and then accumulates a third one, and now we're starting to hit genes that are important not only in just how quickly we grow, but in how invasive perhaps the cell can be, and go on and so forth, and you end up with a malignant cell. Okay? So cancer is a series of steps that happens, but all beginning usually with genes involved in growth. And here's a very specific example of how this happens. And this is how colon cancer develops. And this is probably one of the most well-studied pathways in terms of cancer development. So we start out here with the normal lining of the colon, normal epithelium. And the very first thing that happens is a mutation in a gene called APC. And APC is associated with a condition called familial adenomatous polyposis, which is basically just multiple polyps that develop and can develop into cancer. It functions as a tumor suppressor gene. So when we lose that tumor suppression, the growth rate begins to increase, and we start to see what's called proliferative epithelium, meaning the epithelium starts to grow faster, so you can start to see it's beginning to pick. And then we get another change in another gene that's actually involved in inflammation, and so we start to grow into what's called a small adenoma, essentially a small polyp. Now these cells are growing faster. We can't correct the mutations as well as we were back here. And so a new mutation arises, this time in an oncogene called KRAS. That polyp proliferates even faster, and again, two more mutations hit, both in tumor suppressor genes, one called P53, and then there's a tumor suppressor gene on chromosome 18. And in this case now we've lost that entire piece of that chromosome, and we end up with colon cancer. Now, this whole process, at least in colon cancer, typically takes about 10 years. So it's not an overnight thing that's happening. But this is part of the reason why when you begin to get your colonoscopies, if you have a completely clear colonoscopy, you're typically good for 10 years because they know that if they didn't see any polyps or anything like that, then it's going to take 10 years before any of this were to begin to develop. If they did find some polyps, that's when they say, you need to come back a little bit sooner because you've already moved along on this pathway. Okay. So, all that being said, yes, all cancer is in fact genetic, meaning that problems in your genes do lead to cancer. But not all cancer is hereditary. Okay? And in fact, about 70 to 80% of cancer is what we call sporadic, meaning there's no family history, there's no genetic predisposition, it was just based on your age and your environmental exposures and your gender that you were predisposed to cancer. About 5 to 10% of the time we actually do see hereditary cancer that's being transmitted within a family, and I'll show you how it gets transmitted. But then there's a group here, about 15 to 20%, where it's not clearly hereditary, but it's not sporadic either, and it's what we call familial clustering. And what that means is we're seeing families where there's more than one cancer more commonly than what we would have anticipated just based on general population risk. But it doesn't fit into a well-known syndrome like hereditary breast cancer, for example. Okay? And I'll show you kind of what that looks like a little bit later. So we're going to focus right now on the hereditary breast cancers. Now, the idea behind the hereditary breast cancer goes back to a hypothesis named after a person named Knudsen. And Knudsen proposed this two-hit hypothesis. And if you remember before, when I mentioned oncogenes and tumor suppressor genes, we said most hereditary cancer syndromes are due to problems in tumor suppressor genes. And remember, you have two copies of these tumor suppressor genes. So we're going to look down here at the non-hereditary forms. And it takes time before you get that first mutation because your ability to repair DNA is actually pretty good, but after a few years, perhaps you get a first mutation, and then another period of time, and you get a second mutation, and that's what leads to the cancer. And this is the reason why most individuals with cancer tend to be on the older side, because it just takes time to accumulate that. In the hereditary cancers, though, you're born with already one of those copies being mutated. So the time it takes for you to get that first mutation that's going to lead to cancer is much shorter. So one of the most important features that we look for in a hereditary cancer syndrome is actually age of onset. And that's why you'll hear, if a woman is presenting with breast cancer before age 50, we get particularly concerned about that, because that's awfully soon to have just gone through the normal process and had 2 hits. It's not impossible, it's just a little bit more unusual, and this is where this begins to make more sense. The other thing that we'll see, in addition to younger age of onset, is bilateral disease. So for a woman to have breast cancer on the right side that's treated, and then to come back a few years later and then have breast cancer on the left that is a new primary cancer, would also be very unusual. And again, makes us think, was there already a predisposition there? So why do we want to capture these individuals? Well, obviously, their treatment may be different, and their surveillance may be different because they're at an increased risk, but also because we want to identify other individuals in the family who may also be at risk, because surveillance is so important for a number of these conditions. So here is a family. Is everyone familiar with this sort of diagram? I'll just to give you some quick basics. This is what we call a pedigree. This allows us to sort of analyze a family history and look for any patterns of inheritance that are happening. We use squares for males and circles for females, and if someone is affected, we usually color them in, okay? Now, this here shows that there was a union between this man and this woman, and they had 3 children, 2 females and 1 male. So when the line comes off the side, it means a union, so here was another union. When the line comes down, it usually means an offspring, okay? So in this family, for example, we had a union here between a male and a female. This male was affected with some condition. They had 1 daughter who was also affected. She had a union with this individual who comes from a family with no history of the condition. And then they have 3 children, 2 of whom apparently inherit the condition and 1 who does not. And then these 2 affected individuals then had unions, and this couple had 2 kids, and this couple had 3 kids. And again, 2 of the 3 have the condition here, and 1 out of the 2 have the condition here. So when we're analyzing a pedigree like this, what are the things we notice? Well, as genetics professionals, we say, well, the first thing is that this condition is being inherited from one generation to the next. That usually points us towards a dominant condition, because recessive conditions don't usually get passed on like that. We also notice that the proportion of males to females in the family who are affected are relatively equal. So we've got 4 males and 3 females. So when we see that, it usually tells us this is probably not due to a gene on the X chromosome, because women have 2 X chromosomes and often can compensate for a disorder because they have a second X, whereas males don't. So if we see a predominance of males in the family, then we start to think maybe this is something on the X chromosome. Here it's not. So this is probably one of the other chromosomes that are equal in males and females. And we're also noticing roughly a 50% chance for the condition to be passed on. Now remember, it's like a coin toss, and probability has no memory, so it's 50-50 with each pregnancy. And so, they only had 1 child, so it was a 50-50 shot. This couple had 3 kids. It was a 50-50 shot with each one. It just happened that 2 out of the 3 got it. Same thing here, same thing here. So when we see those particular traits in a family history, we usually think about autosomal dominant inheritance. And autosomal is simply separating this out from an X-linked condition. Okay, so all your other chromosomes are called your autosomes. Your X and your Y are called your sex chromosomes. If this were a sex chromosome, if this looked like it had male predisposition, then we would call it X-linked dominant. And most of the cancer syndromes are actually inherited in this type of fashion, so we look for this type of a family history. Our family history really, when we're trying to differentiate the hereditary cancer syndromes, is the most important thing that we have, above all else. Our genetic counselors will collect the information, draw it in the pedigree, look for those patterns, And when we find affected individuals, there are particular questions we ask. We want to know who was it that had cancer, how old were they when they were diagnosed with cancer, what kind of cancer was it, and what type of treatment did they receive. We also want to know any environmental risk factors. So for example, if a family member reports esophageal cancer, the next question I ask is, well, did that person drink or did they smoke? Because those are risk factors for that. Or if someone is showing up with lung cancer, I always ask about smoking, because if you have lung cancer in the absence of smoking, that is a little bit unusual. We need to kind of investigate that a little bit further. And then, of course, there are always challenges when we're trying to get this data. So, for example, when there is an estranged family member who had cancer but is very secretive, sometimes we can't quite get the information we need. Sometimes the history that we're getting is, I don't like the word untrue, it's inaccurate, not because the patient is intentionally trying to deceive us, but because, for example, they just know what they heard. So if they said, Uncle so-and-so died of liver cancer, they're going to report liver cancer, even though most liver cancers are actually metastatic from somewhere else. And so we have to often dig a little bit further to make sure that it was indeed that type of cancer, or if it was originated somewhere else. In the US generally, compared to other countries, we have relatively smaller family numbers, and therefore, if you remember, probability shows up more accurately the larger the numbers you have. And so because of the small family size, sometimes we won't always be able to detect a clear pattern. We can also have individuals in the family who die early, and remember, it does take time to develop cancer. So if an individual, say a male, were to have inherited a mutation that causes colon cancer, but he died in a car accident at 18, then he wouldn't, have lived long enough to manifest that. And so we always have to keep that in mind when we're analyzing family histories. And then an interesting feature is diseases that are sex-influenced. Hereditary breast cancer is a great example of this. Men can inherit the same breast cancer mutation that women can at equal proportions as women can, because the gene is not on the X chromosome. Okay? However, just because of biology, men will be less likely to manifest it. Now, you can have male breast cancer, but it's much, much rarer because of the amount of tissue that they usually have. But when we're looking at family histories for breast cancer, for example, it'll look like it's predominant in women, and it is, but that's more a feature of the disease itself, not because the genetics are any different. So we're still looking for that same pattern, just recognizing that when it goes through a male, it may not manifest. So things that we're also looking for in the family history, obviously multiple individuals with cancer, multiple generations that are affected, and are the cancers somehow related? Are we seeing mostly breast and ovarian cancer, for example, like what we see with the RCA1 and 2? Or are we seeing a mix that we can't quite link together? Obviously, the younger ages of onset and the autosomal dominant pattern. And then are we seeing some rare cancers more commonly than we would anticipate in that particular family? Do the individuals who have cancer have multiple primary cancers? So was there an individual who had both a breast and an ovarian cancer? That's a little bit more suspicious for us. And then did they have bilateral disease? And then finally, if you're finding a cancer that has a well-described environmental risk factor, but they didn't have that risk factor, we need to look a little bit closer as well. So here is an example of a family, and the arrow points to the individual who's coming to see us, and this female is coming to see us because she's concerned about her risk for breast cancer. So we take the family history, and we find out that her mother was diagnosed with breast cancer at 42, and then she had a first cousin through an uncle who had breast cancer at 38, and then her maternal grandmother died of ovarian cancer and was diagnosed at 49, and also another maternal aunt diagnosed with ovarian cancer at 53. So this is a very suspicious pedigree for several reasons. Number one, the age of onset of the cancers is relatively young. Two, the types of cancers we see are related. Breast and ovarian cancer we know go together. Three, it's involving multiple generations, at least 3 in this case. And if you try to look at the inheritance pattern, remember, we said, it looks like there's a predominance of females, but in fact, this male is what connects these two females. So this male may inherit that mutation, just never manifested it because he doesn't have significant amounts of breast tissue or ovarian tissue. Okay? So it looks very much like an autosomal dominant inherited condition. And this is what we call HBOC, or hereditary breast and ovarian cancer. That was a very typical family history that we get. And it's important to identify this because there are significant lifetime risks for cancer in the patient who presented to us. So, for example, the risk of breast cancer in HBOC ranges from about 40 to 80% lifetime risk, which is much higher than the population risk of 13%. Okay? They tend to have what's called triple-negative breast cancer, so they're a little bit different in terms of their treatment. The risk of ovarian cancer is also significantly increased, up to 40%. And then male breast cancer, we'll see much higher. So if you are a man with a BRCA2 mutation, for example, your breast cancer risk may be as high as 10%, which is 100 times more common than it is in the general population. There's a few other cancers that are also increased, because remember, these are tumor suppressor genes, and they can suppress other types of tumors besides just breast and ovarian. So prostate cancer, pancreatic cancer, and melanoma are also increased for this population. And these are two tables just showing you, for women, depending on whether they have a mutation in BRCA1 or BRCA2. So these are two different genes, both tumor suppressor genes, that are important in breast and ovarian cancer. And you can see there's some slight differences between whether you have the mutation in one or two. And that's why it's important to know which gene is involved. And these are the average numbers in the population, so you can kind of compare. You can see significant differences for breast and ovarian cancer, a little bit of an increased risk for pancreatic, and a little bit of increased risk for melanoma. And then when you look at the males, same thing. Breast is increased, prostate a little bit increased compared to what their normal risk would be, and then same pancreatic and melanoma. As I mentioned, the genes are BRCA1 and 2. They're autosomal dominant in the way that they are inherited, so it's 50-50 chance. So the patient that we saw earlier who presented to us would have a 50% chance of having inherited that. And there are three particular common mutations seen in the Ashkenazi Jewish population. So whenever we take our family histories, we always ask about ancestry because we want to know, are they also at increased risk for something based on their family history? And if we get a history that they're of Ashkenazi Jewish descent, then we often will think about those three mutations for testing. When a patient is identified with HBOC, obviously the next question that usually comes up is, well, what do we do about it? And so obviously increased screening is very important. Both self-breast exams and clinical breast exams are important. But initiating mammograms and even breast MRI are going to be very important. And the reason here is that, remember, the age of onset of the breast cancer is earlier, when the tissues are denser and mammograms may not be the most effective way to screen. So breast MRI becomes very, very important. There have also been some theories that because these genes involved in tumor suppression can predispose to accumulation of mutations, is the radiation from a mammogram potentially add some harm compared to a breast MRI? I think the newer versions of mammograms are really good in terms of reducing that, but that has been brought up in the past. For the ovarian cancer issue, this is a problem. We have not been able to find good screening methods for that. So pelvic ultrasound and biomarkers in the blood, for example, CA-125, they've looked at this, and it's not detecting the cancer any earlier. So when we think about screening, we also think about, are there things we can do to mitigate the risk? So prophylactic bilateral mastectomies, for example, is something that would be offered. And part of that is just going to depend on the risk tolerance of the patient. So if the patient says, gosh, that increase in number, is just going to sit on my mind all the time, is going to impair my quality of life, even though I know I'm going and getting my breast MRIs and my mammograms, then that may be a reasonable option for them to mitigate that risk. With the ovarian cancer, After childbearing years, obviously offering removal of the ovarian tissue as well as the fallopian tubes, because they also have an increased risk there, is something that would be offered. And then there's some individuals that would be offered chemoprevention to help reduce that risk. But again, it's a discussion that we have with each patient, and a lot of it depends on the tolerance of risk and how much will the risk be reduced by these procedures. So here's another family. Again, our arrow is pointing to the individual who's showing up. It's a 46-year-old female. And she has a father. She has two older siblings who are fine. She has a father who died of colon cancer at 66, was diagnosed at 65. And then he had a father who was diagnosed with lung cancer at 72, had a positive smoking history. So that's not particularly unusual. No other family history on that side. On her mother's side, however, she has a maternal uncle who was diagnosed with colon cancer at 59, so quite young, still alive at 78. She has a maternal aunt who was diagnosed with melanoma at 52. And then her grandmother on that side was diagnosed with colon cancer, and she has an aunt who's been diagnosed with colon polyps at 54. So this one is looking obviously different than the last family history we looked at. Also appears to be, at least in 2 generations, incidence of colon cancer and polyps. And then this melanoma may or may not be related. If you look at the genders that are impacted, it's roughly similar, but the problem is, again, it's a very small family, so you can't be sure about that. When we see this kind of pattern, we think about something called Lynch syndrome. And Lynch syndrome, the other name for that is hereditary non-polyposis colorectal cancer syndrome. And the non-polyposis is actually a misnomer. So there's a very well-known colon cancer syndrome called FAP, or familial adenomatous polyposis. This is a condition where patients will show up with hundreds of polyps in the colon, which is very different from Lynch syndrome. Lynch syndrome patients will also have polyps, but they won't have quite that many polyps. And so they use that HNPCC to distinguish it. And actually now I think people are going back to the term Lynch syndrome. But what do we see in these patients? We see obviously increased risk for colorectal cancer. That's the big one, up to 80% lifetime risk. But we also see endometrial cancer, up to 60%. We do see some ovarian cancer, gastric cancer, and several other conditions, including melanoma. So that's where that fit into that particular family. And again, it's because these are tumor suppressor genes, so they can impact multiple organs. But they seem to be important in some organs more than others. There are actually several genes that cause Lynch syndrome. What's most important is that all of these genes function in a have a very similar function. They all have a role in what we call DNA mismatch repair. So if you remember when we went back to when we were talking about having time to edit a paper, these are the genes that do that. Every time your DNA is copied, when a cell is dividing, these genes go through that DNA and make sure that all the sequence that's been copied was copied accurately. And if it finds any errors, it will fix them. So you can imagine if you have a mutation in one of these genes and that gene is not working quite as well, then you're going to be predisposed to accumulating mutations. There are some tests that can be run on the tumor tissue itself to tell us if there's a problem in the DNA repair mechanism, and those are called microsatellite instability tests. Basically what they do is they take the tumor tissue and they analyze the DNA and they look to see does the DNA look unstable? In other words, are there certain areas of it that will, when you handle it in the laboratory, will begin to accumulate mutations? And if it's already showing that in the lab, that tells you that there's probably a problem in the patient. However, more recently, we're getting better and better and better at doing blood testing for this. And so that, I think most Lynch syndrome is now being diagnosed using blood testing, whereas in the past, they were really using the tumor testing for that. And just like with HBOC, with breast cancer, it's also showing an autosomal dominant inheritance pattern. The management for Lynch syndrome, again, routine colonoscopies, but we start much, much earlier than the general population is recommended. And again, that's just because they're born already with one mutation and so can accumulate that sooner. And often we'll use family history to kind of predict when we should begin screening. So if the youngest person in the family to have colon cancer was at 30, we usually want to start screening 10 years before that. So remember, we have that 10-year process, and so we would actually begin screening at 20 in that particular family. For Lynch syndrome, prophylactic colectomy, or removing the colon, is not recommended, and that's because the colonoscopies are really, really, really effective screening, and the change in the person's lifestyle from a complete colectomy is really significant, and so you wouldn't want to do that unless there was a good reason for it. In that other condition I mentioned, FAP, they do actually look at colectomy because there are just so many polyps that develop, you can't keep up with them with colonoscopy. And because of the issues with ovarian and uterine cancer, once childbearing is complete, prophylactic removal of that is offered. And again, it's because there's really no good screening, particularly for ovarian cancer. So here's our third family. This is a 35-year-old male here that's presenting, and the concern is on the male side of this family, his father was diagnosed with lung cancer at 52. He was a smoker. He had, both of his parents had cancer. His father had prostate cancer at 81, and his mother had breast cancer at 75. And then he had an aunt with colon cancer at 72, and then an uncle on his dad's side with liver cancer, but was alcoholic. So when you look at this family history, you know, it's not screening hereditary breast and ovarian cancer. It's not screening Lynch syndrome. It's kind of a mishmash of different cancers that are going on. But it's definitely more than what you would expect for the general population. So this is what we call familial clustering. It's probably not due to any single gene, but there may be some susceptibility genes that are being passed on in this family. And that could increase his risk above the general population risk. Not to the same level as, say, hereditary breast and ovarian cancer or Lynch syndrome, but still increase above the general population. So, when we're assessing families like this, you know, we look at not only their family history, but what are their personal risk factors? Are there things this individual can do to mitigate their risk? You know, what's their diet look like? For breast cancer, for example, age of first live birth and breastfeeding, because hormonal effects can play a role there. For women, what's the age at which they go through menopause, and what was the age that they started having their menstrual cycles? And are they using birth control or hormone replacement? So we look at those things to see if we can adjust the risk. And then we have some additional models that can help us out. These are different types of models we use, but you basically enter the family history of who had cancer at what age, and the algorithm will calculate what sort of conditions the particular patient who's showing up is at risk for. And so you may adjust surveillance based on that. You may start screening a little bit earlier. You may try to do some dietary or risk modification, that kind of thing. So that's how we handle the family clustering group. But we don't really have testing to offer because we don't fully understand what's contributing in that situation. For those who are clearly following a genetic pattern, we do have molecular testing. We can analyze the genes that we know are associated with those conditions to see if we can find a cause. And when we run these kinds of tests, there are typically 3 results that we get out of it. So say we have a family with what appears to be breast and ovarian cancer, and we want to analyze BRCA1 and 2. When we talk to patients about this, we say, well, there's 3 potential outcomes that we could get. Number 1 is a positive result, or what we call a deleterious mutation, and that just means we found a change in one of your genes that's been seen in somebody else with breast and ovarian cancer, or hereditary breast and ovarian cancer. That's very clear. Or the result is negative, and we say, well, that doesn't look like it's causing whatever condition is going on in you. Or we can get what's called a variant of uncertain significance, or a VUS. And these are so much fun to deal with. And the reason that we get those is because the laboratory has identified a sequence change from what we call the reference genome, meaning what most people have, And that change has neither been seen in a person with hereditary breast and ovarian cancer, nor has it been seen in the normal population. So it's something that's unique to that patient and their family. Now, what do we do with VUSs? Well, we try to decide by looking at where is it in the gene. Is it in an important part of the gene that's really plays a key role, or is it sitting in a part of the gene that's not so important? We look at the nature of the change. How significant of a change is it? Is it one that we would predict it's going to completely knock out the function of the gene, or is it one that's only going to slightly alter it? And so we try to see whether it's truly uncertain, or does it sort of lean towards being a deleterious mutation, or lean towards being a benign mutation. And then we try to make a call on it. And sometimes it's still just a VUS, and there's not much we can do with that. And so we counsel patients about that, and we'll follow up periodically, because as more and more people get tested, we get more and more information about the genome, and sometimes these VUSs get reclassified as the years go on. As more and more genes are identified, we're shifting from just sequencing 1 or 2 genes to actually doing panel testing. So laboratories, because of advances in technology, can offer panel tests at relatively low cost, whereas in the past you had to pay for each gene you wanted to analyze. So this is a really great breakthrough. And there are lots of genetic testing companies now that are offering these panel tests. And in fact, we offer these as well at our institution. So now the testing strategy comes into play. So who actually should we test? We use our family history to decide, but sometimes it's not our patient who's the best person to test. When we think about a test, we think about the size of the panel that we want to do. Is it very clear BRCA1 and 2? Or is it maybe not so much, and we need to incorporate more genes that can be associated with breast cancer? Keeping in mind that the larger the panel you choose, the greater the likelihood you may find a VUS. Okay? That's just the nature of sequencing DNA. And then preparing them with results ahead of time. So, like we said, sometimes the patient doesn't have cancer themselves, but it's their first or second degree relative who actually has the cancer. We're more likely to find the mutation if we go with the person who's been impacted by the disease than the person who's showing up. And we also want to know that when we're testing the patient, that a negative result really means negative, right? In other words, do we know exactly what's causing the particular cancer in this family? And so if we test the patient for a couple of genes and they're negative, but the family's cancer is due to a different gene that's not in those 2 genes, we haven't really done our patient any service. So here's an example. This is a patient, a female who's showing up and asking for potential testing. You look at the family history, again, 3 generations of ovarian and breast cancer. It's the same pedigree we looked at earlier. And so the question then becomes, well, who's the best person to test here? Who would you think we should go after? Yeah, her mom, right? And that's because her mom had breast cancer at an early age, and she's the closest relative to this individual. Even though this person is younger, her cousin, this person is 1, 2, 3 degrees away from her. And so that's not an ideal person to test. You want to pick the closest relative with the most, who still has suspicious findings. But what if this is the family history? What if all the people with cancer are now deceased and we don't have tissue from them? In this situation, you can't test the best person. And so then you have to decide what kind of testing do we offer the person in front of us. If the pedigree is a classic BRCA1 type of pedigree, then what we would probably do is do BRCA1 and 2 testing, because it's looking really suspicious. If some of this was a little bit variable, maybe didn't completely fit, then we might pick a larger panel to do. Now, if we were to run testing, and these were, say, the 4 different potential test results, which one of these would actually be most informative for the patient? Either a VUS on BRCA1 or 2 testing, or a negative 7-gene breast panel that included those 2 genes, or a VUS in P10, which is one of those other genes in that panel, or a positive BRCA2 test. So which of those would actually tell us something of value for the patient?
The last one.
Yes, absolutely. This one, without a doubt, will say, okay, you do have this change. It's been seen in other people with hereditary breast and ovarian cancer, and now we need to address that for you. So that's very informative. The VUSs obviously are not going to be helpful because we don't know if anyone else who had cancer had those same VUSs. And a negative test, is that a true negative? We don't know because we weren't able to test any of the other individuals. So we go through a number of things before the test is even done. We talk about it all on the front end. We talk particularly about management options. In other words, what are you going to do with this information? If it's positive, what are you going to do with it? If it's negative, what are you going to do with it? And really try to help the patient think through all of that. Because if it doesn't change anything for them, what's the value in them knowing? Is it for their family? Is it for their children? You know? And then one of the questions that often comes up is this going to affect my insurance? If I'm found to have a mutation, is it going to impact my health insurance? Is it going to impact my employment? Is it going to impact my life insurance? And so we always remind patients that there was a law passed in 2008 called GINA, the Genetic Information Non-Discrimination Act. And this protects patients' employment and their health insurance. It doesn't impact the health insurance rate, but it does mean they can't be denied for health insurance. But it does not protect life insurance. So if you try to go get life insurance and the insurance company knows that you have a BRCA mutation, then they can deny you life insurance. It also doesn't protect people in the military. And so there are some caveats to it. And so we talk through this with the patients because they need to be prepared before they undergo testing. And then, of course, on the post-test side, we review the information, talk about what are they going to do if they get a positive result, get them connected to the right specialist for management and surveillance, empower them about their own management because sometimes they're that best advocate for what they need. And then for some individuals, they like to have a community of people out there who are dealing with the same thing, and so getting them connected with some support groups can be helpful. If it's negative, we make sure that it's a true negative, that we're not giving them false reassurance, and we remind them, you still have the same general population risk, say for breast cancer, as anybody else, even if you have a negative result. So your risk doesn't go to 0, it goes down to that 13%, and so you still have to get routine surveillance. Some people will have survivor guilt. If they had several siblings who experienced breast and ovarian cancer and they happen to be fortunate to not have it, then they can have that experience. And then just making sure they remember surveillance. And then our counselors are really good about connecting them when they choose to have that level of support. How are we on time right now?
We have about 8 minutes left.
8 minutes left. Okay, so I'm going to do this very, very quickly. Has anyone familiar with non-invasive prenatal screening? Has anyone heard about this? So in the past, we used to look at various markers in the blood as well as ultrasound in pregnancies to screen for various chromosome conditions like Down syndrome and other abnormalities. But recently, it's been determined that because the baby makes the placenta, and the placenta releases DNA into the maternal bloodstream, we can actually obtain that DNA from the maternal bloodstream and analyze it in a much more accurate way than we did before. The interesting thing, though, with this has been out now, probably 7 or 8 years. The interesting thing is that sometimes we'll find abnormalities in the results that suggest, say, Down syndrome or some other condition, but the baby is perfectly fine. And the question is, what do you do with that? And so this woman at Yale, Diana Bianchi, who's been really focused on things circulating in pregnant women's blood, has found is that you really need to look at the mother because there may be some other things going on in her that are causing these discrepancies. And let me just go to here. So this was a Belgian study on 4,000 patients who all had this screening test. And 3 out of the 4,000 had normal babies, but they had an abnormal test that was reproducible. So they guaranteed, yes, there is something going on here. There's an abnormal amount of DNA circulating in this woman's blood. And it turned out that they had cancer. Remember, cancer is due to mutations and changes in your DNA, and this test was actually picking those up. What they did for those individuals was they sent them through whole body MRI because they weren't symptomatic, and they were finding ovarian cancer in one, lymphoma in another, and Hodgkin's lymphoma in another individual. And so they started looking at this more and more, this is just in the last couple of years, and again, beginning to find cancers before the patient is even symptomatic by using this very, very sensitive DNA-based technology. So, I'm just going to jump quickly, since we're running out of time. Whoops. To here. What we've determined over the last few years is that this screening test can detect maternal malignancies of multiple origins before the patient develops symptoms and before you can even find anything on physical exam or lab workup. And again, it's because it's designed to pick up very, very, very minute changes within the DNA. It seems to lead to earlier diagnosis. What we don't know is, will it lead to a better treatment outcome? Okay, potentially it could, but we don't know that for sure. But the other thing we've seen is that when patients get treated, the test result goes back to normal. And so it's a really good predictor of whether they're in true remission or not. Okay.
What does NIT stand for?
Non-invasive prenatal screening.
Okay.
So I just wanted to mention this because it's hot off the press. People are really looking at it. And the laboratory that developed the test is now beginning to see there is an oncologic use for this particular test. And it may be that in the future, instead of going to get mammograms and colonoscopies, you may just get a blood test that's going to screen for these DNA modifications and at your annual visit. And you may get treatment for cancer before you ever were symptomatic. So, very exciting stuff in the world of genetics. And with that, I think I will stop and take some questions. Yes?
I was diagnosed with ovarian cancer, stage 3, and I have no history of any cancer on either side of my family. And of course, everybody that's older than me is dead, so there's no testing available. And my doctor suggested that I be tested for the BRCA2, and I went through the genetic thing, and they said, well, you don't have any history anywhere, blah, 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 so I didn't bother to do it. Well, then a new regimen came up that if I had it, I would be able to have it if I would go out of remission. So anyway, so I decided to have it, just to have it, and they tested for 19 different genes, and the only one that turned up positive was a BRCA2.
Wow.
Oh, it's like, what the heck?
Yeah.
And I have no, is that, I wondered why.
Yes.
You could give me an answer.
Yeah. So that's a great question. Number one, remember that these mutations, when they arise, they can arise in the patient you're seeing for the first time, right? As opposed to being inherited from multiple generations. Because it happened in someone the first time. And so it may be that for you were the first person to have it, which means it may have arisen when you were just an embryo, okay? So that's when the mutation can first happen, and then it can be passed on subsequent to that. So that person's descendants can be at risk. Number two, I think in more recent years they've recognized that ovarian cancer at any age probably needs to get tested. Whereas in the past they were a bit more strict in terms of applying the testing. And they think, I think it's just the nature of the ovarian cancer biology and the link between ovarian cancer and hereditary breast and ovarian cancer that's driving that. So in fact, right now, the NIH is putting out a number of, they're funding a number of studies to try and get more people with ovarian cancer tested because they weren't doing it routinely in the past. And if you look at the number of patients who should have ovarian cancer and the number of patients who are getting tested, it's only a tiny fraction. So there are probably a lot of individuals out there, like yourself, who didn't get tested, but probably should have been, because it does modify the regimen.
Well, yeah, and I thought, because I would have, I've always had a mammogram and all that kind of stuff like that.
Right.
And monitored that, but, the other thing, was totally a surprise thing when it was diagnosed.
Yeah.
But anyway, my son was since been tested, and my daughter is positive. And she's going to have next week, actually, on her, a total hysterectomy. And then we're both going to go through the monitoring, the mammogram and
Right.
MRI thing.
Right.
But my son was negative, but my daughter has 4 daughters.
Yeah. This is.
So I have that kind of guilt thing, you know, but we're talking about.
Oh, yeah, so I mentioned survivor's guilt, but there is also guilt when the parent believes that they passed it on.
Yeah.
Yeah, no, that's understandable. And we tell people, I mean, you wouldn't have been expected to know that you were going to pass that on.
Yes, can you speak just a moment to the risk of ovarian cancer in a BRCA patient? Premenopausal, postmenopausal, does the risk decrease significantly if they're postmenopausal? Like if I have a patient that's 66 years old, she's got breast cancer, we find out she's BRCA. Should she have her ovaries removed regardless of how old she is?
Oh, right, so the risk is always there.
Always, and it's always
there.
the same, premenopausal, postmenopausal?
Correct.
Okay.
Yeah, these are tumors that are not necessarily hormonal driven, because they're driven at the genetic level.
And the other ones that are hormonal, I'm going to back up. Those were where you got the 2 and the 1 was.
Yes.
Those aren't specific to any type of cancer.
No, all of them act like that,
Yeah.
pretty much.
How do you handle situations where you cannot do testing and you have to try to do medical reports and you can't have access to them because they no longer exist? How authentic or how true are your results? Or
Do you mean like if you're wanting to test a patient who doesn't have cancer because no one else is available for testing, or?
yes, they're deceased and then you do not have access to medical records. I mean, do you just how do
you
set up?
have to make you have to make your best guess sometimes.
Okay.
No, you're right. It's challenging, or sometimes they're not deceased. They just don't want to share any of their information, which they're entitled to do. So we just make the best guess, and I usually sort of lean towards worst case scenario. Right? What's the worst case here that we wouldn't want to miss?
What are medical records? How long do they have to keep most medical records? Is there a limitation or statute on that?
Gosh, so I was under the impression, and I can't remember when this changed, but at some point in time it became, I thought it was indefinite. You know, I thought you had to always maintain them somewhere. But how readily available they have to be is not regulated. So you can send them off for, storage somewhere.
It's not indefinite.
Yeah, it's not indefinite.
Is it not
Some
indefinite?
places some states it's 7 years and some
10
states
years,
it's
yeah.
10.
Wow. That's not very long.
And even, the tumor banks or tissue banks, it's 10 years.
What are your thoughts on the direct-to-consumer testing that's popping up every day?
That's a great question, which I didn't have time to tackle. So I have to be honest, I'm very torn. I believe in the democratization of your genetic information because I think it can empower people. My concern, so the big one right now is 23andMe is testing for a few of the BRCA mutations. My concern is in the absence of appropriate pre- and post-test counseling, are individuals going to understand what a negative result actually means? Okay, if they get a positive result, that's pretty straightforward, and then they know they're going to have to take some additional steps. But did they consider GINA? Did they consider life insurance before they got tested? I don't know that. And then if it's negative, does it give them false reassurance and then they don't get their normal screening? So I have a lot of concerns about direct-to-consumer testing right now. I mean, I believe that the more people who have access to genetic testing who want it is a good thing, but there needs to be the whole package, which includes the pre- and post-test counseling.
Any other questions before we let Dr. Robin?
I just have one.
Okay.
I did my genetic testing for breast cancer, and I believe the panel size is 27. Has that grown? I mean, have we discovered new? What are we up to?
Yeah. So there is actually a all cancer panel that's up to about almost 60 genes now. The breast, I think, is running close to about 30 genes if we're just focused on those. But yeah, and that'll likely continue to grow. There are 22,000 genes in the human genome. We only understand maybe 7,000 of them. There's a whole other 15,000 genes we don't know anything about.
What are you doing?